Kidney transplant. Kidney transplantation involves transplanting a kidney from a living or deceased donor to a recipient who no longer has renal function. A living donor is a person who is alive at the time of the donation and may or may not be related to the patient. A deceased or cadaveric transplant comes from someone who has died and donated their organs. Kidney transplantation is an elective procedure, not an emergency life-saving procedure. Therefore, patients should be in the best possible condition prior to transplantation. The recipient's native kidneys are not usually removed. The transplanted kidney is placed in the patient's iliac fossa anterior to the iliac crest because it allows for easier access to the blood supply needed to perfuse the kidney. The ureter of the newly transplanted kidney is transplanted into the bladder or anastomosed to the ureter of the patient. Once the blood supply has been established, the transplanted kidney in the operating room, urine should begin to flow. The production of urine at this stage is an important indicator of the overall success of the procedure and ultimate long-term outcome. So for the purpose of this procedure, kidney transplantation has become the treatment of choice for most patients with end-stage kidney disease. Patients choose kidney transplantation for various reasons, such as the desire to avoid dialysis or to improve their sense of well-being and the wish to lead a more normal life. In addition, the cost of maintaining a successful transplantation is one-third the cost of dialysis treatment. Prior to receiving or donating an organ, an extensive medical evaluation is performed. Not everyone is suitable for kidney transplantation. So for the indications, any condition that leads to end-stage renal or kidney disease, which are diabetes, glomerulonephritis, pyelonephritis, polycystic kidney disease, obstructive uropathy, congenital urinary tract abnormalities, Alport's disease, hypertensive nephrosclerosis, reflux nephropathy, interstitial nephritis, Goodpasture syndrome, hemolytic uremic syndrome, chemical nephrotoxicity, renal artery emboli, and sickle cell nephropathy. So for the contraindications, it includes recent malignancy, active or chronic infection, severe irreversible extrarenal disease, active infection, class 2 obesity, current substance abuse, inability to give informed consent, and history of non-adherence to treatment regimens. Donors may be rejected for the same reasons or any condition that is determined to have an impact on the remaining kidney. Examples include hypertension and diabetes, because both are known causes of kidney disease. So next is for the potential complications. First is the early complications of kidney transplant. Early complications include risk of abscesses within abdominal walls. This is more likely in old, obese, and diabetic patients. Bleeding is another common complication immediately after surgery. Bleeding in urine or hematuria may also be seen in some patients. A major abdominal surgery weakens the abdominal muscles and may lead to a risk of abdominal hernias over the site of the incision called incisional hernia. Obese diabetics, those with rejection, are more at risk. Some patients may develop infectious tracts or canals called urinary fistulae. There is a risk of post-operative formation of blood clots or arterial thrombosis. This may get dislodged from the operative site and travel up to the lungs or brain, leading to life-threatening complications. Next is late complications of kidney transplant. Late complications include narrowing of the ureters an obstruction to flow of urine from kidney into the bladder. This is called ureteric stenosis. Pyelonephritis, or infection of the kidneys after surgery, is another complication to be watching out for. Some infections are common, especially due to use of immunosuppressant mediations. These are termed opportunistic infections and include herpes simplex infection in the first 4 weeks, and then cytomegalovirus infection. Fungal and bacterial infections are also seen. Kidney stones may be transplanted with the donor kidney or may form later in the new kidney. There may be manifestations of blood in urine or hematuria, infections, and obstruction. Renal artery stenosis, or narrowing of the renal arteries, is a late complication. There may be developed of other blood vessel abnormalities like arteriovenous fistulae and pseudoaneurysms. Some patients may also develop lymph channel abnormalities called lymphocysts. Over long term, they may be a risk of cancers or of skin or lymphomas. This could be due to the use of immunosuppressant mediations. Common cancers include Kaposi sarcoma, kidney cancer, and in women, cervical cancer. Heart disease like high blood pressure, high cholesterol, etc. are common after kidney transplant. Recurrence of the original kidney dysfunction that damages the new kidney is another complication of kidney transplant. And now let us move on to the preoperative management. Preoperative management goals include bringing the patient's metabolic state to a level as close to normal as possible through diet, possibly dialysis, and medical management, making sure that the patient is free of infection, and preparing the patient for surgery and the post-operative course. Next is for the medical management. A complete physical examination is performed on the donor and the recipient to detect and treat any conditions that could cause complications after the donor and transplantation procedure. Tissue typing, blood typing, and antibody screening are performed to determine compatibility of the tissues and cells of the donor and recipient. Other diagnostic tests must be completed to identify conditions requiring treatment before transplantation for either individual. The lower urinary tract is studied to assess bladder neck function and to detect ureteral reflux. Both patients must be free of infection at the time of kidney transplantation. After surgery, medications to prevent transplant rejection will be prescribed to the transplant recipient. These medications suppress the immune response, leaving the patient immunosuppressed and at risk for infection. Therefore, both the donor and recipient are evaluated and treated for any infections, including gingival or gum disease and dental caries. A psychosocial evaluation is conducted to assess the organ recipient's ability to adjust to the transplant, coping styles, social history, social support available, and financial resources. A history of psychiatric illness is important to obtain because psychiatric conditions are often aggravated by the corticosteroids needed for immunosuppression after transplantation. So next is the post-operative management. The goal of post-operative care is to maintain homeostasis until the transplanted kidney is functioning well. The patient whose kidneys functions immediately has a more favorable prognosis than the patient whose kidneys does not. Often, the organ donor will be on the same unit as the transplant recipient. The donor will require the same level of care provided to the recipient, including follow-up after the procedure and lifelong. The organ donor may experience more pain than the recipient, possibly requiring more analgesia for pain control. Fluid, electrolyte, and hemodynamic status will also be closely monitored in the organ donor. Next is the medical management for post-operative. After a kidney transplantation, rejection and failure can occur within 24 hours, which is called hyperacute, and within 3 to 14 days, which is acute, or after many years. A hyperacute rejection is caused by an immediate antibody-mediated reaction that leads to generalized glomerular capillary thrombosis and necrosis. An acute rejection typically occurs within a few days to weeks of the transplant surgery, and the patient experiences tenderness at the transplant site, a decrease in serum creatinine, and the patient values fever. A decrease in serum creatinine values, fever, malaise, and oliguria. An acute rejection requires early recognition and treatment with immunosuppressant therapy, whereas hyperacute reaction requires immediate removal of the transplanted organ. The long-term survival of a transplanted kidney depends on how well it matches the recipient and how well the body's immune response is controlled. The body's immune system views the transplanted kidney as foreign, therefore it continually works to reject it. To overcome or minimize the body's defense mechanisms, immunosuppressive agents are given. Optimally, medications modify the immune system enough to prevent rejection, although not enough to allow infections or malignancies to occur. Combinations of corticosteroids and medications specifically developed to affect the action of lymphocytes are used to minimize the body's reaction to the transplanted organ. Doses of immunosuppressive agents are often adjusted depending on the patient's immunologic response to the transplant. However, the patient will be required to take some form of immunosuppressive therapy for the entire time that they have the transplanted kidney. For the nursing interventions, first is assessing the patient for transplant rejection. After kidney transplantation, the nurse assesses the patient for signs and symptoms of transplant rejection: oliguria, edema, fever, increasing blood pressure, weight gain, and swelling of or tenderness over the transplanted kidney or graft. Patients receiving cyclosporin may not exhibit the usual signs and symptoms of acute rejection. In these patients, the only sign may be an asymptomatic rise in the serum creatinine level. More than a 20% rise is considered acute rejection. Next, nursing intervention is preventing infection. The results of blood chemistry tests and leukocyte and platelet counts are monitored closely because immunosuppression depresses the formation of leukocytes and platelets. The patient is closely monitored for infection because of susceptibility to impaired healing and infection related to immunosuppressive therapy and complications of kidney disease. Clinical manifestation of infection include shaking, chills, fever, rapid heartbeat or tachycardia, respirations or tachypnea, as well as either an increase or decrease in WBCs or leukocytosis or leukopenia. Next, nursing intervention is to monitor for urinary function. A kidney from a living donor who is related to the patient usually begins to function immediately after surgery and may produce large quantities of dilute urine. A kidney from a cadaver donor may undergo ATN and therefore may not function for 2 to 3 weeks, during which time anuria, oliguria, or polyuria may be present. During this stage, the patient may experience significant changes in fluid and electrolyte status. Therefore, careful monitoring is indicated. Next is addressing psychological concerns. The rejection of transplanted kidney is of great concern to the patient, the family, and the healthcare team for many months. The fear of kidney rejection and the complications of immunosuppressive therapy, Cushing syndrome, diabetes, capillary fragility, osteoporosis, glaucoma, cataracts, acne, nephrotoxicity place tremendous psychological stress on the patient. If the organ donor was a family member, there may be added feelings of guilt and anger that need to be addressed. Anxiety and uncertainty about the future and difficult post-transplantation adjustment are often sources of stress for the patient and family. An important nursing function is the assessment of the patient's stress and coping. Next, nursing intervention is monitoring and managing potential complications. The patient undergoing kidney transplantation is at risk for the post-operative complications that are associated with any surgical procedure. In addition, the patient's physical condition may be compromised because of the effects of the long-standing kidney disease and its treatment. Therefore, careful assessment of the complications related to kidney disease and those associated with major surgery are important aspects of nursing care. Breathing exercises, early ambulation, and care of the surgical incision are important aspects of post-operative care. And lastly is for continuing and transitional care. The patient needs to know that follow-up care after transplantation is a lifelong necessity. Individual verbal and written instructions are provided concerning diet, medication, fluids, daily weight, daily measurement of urine, management of input and output, prevention of infection and chronic rejection, resumption of activity, and avoidance of contact sports in which the transplanted kidney may be injured because of the risk of other potential complications. The patient is followed closely by a healthcare team that includes the nephrologist, transplant surgeon, transplant coordinator or nurse, social worker, and dietitian. Follow up with providers from the transplant team will initially occur once a week upon discharge from the hospital and taper with time. Laboratory studies will also be obtained and followed on a ongoing basis to monitor the function of the kidney. The next video will show you how the procedure is done to give a visualization of the procedure.